Welcome to Deep Dive Ortho, the show where we take a deep dive into complex topics in musculoskeletal health, offering you crucial insights and practical knowledge for your daily practice. Today, we're focusing on a subject that frequently presents in orthopedic clinics and emergency departments, often bring with it a unique set of challenges and subtleties: arm injuries in children. It's a field where distinguishing the subtle from the severe isn't just important, it's paramount to a child's long-term well-being. Understanding the unique pediatric anatomy is absolutely key to getting it right. We'll be exploring everything from the typical playground mishap that sends parents into a panic to more insidious conditions like overuse injuries in young athletes, and even those rare yet critically important complications that can truly be limb-threatening.
Indeed, the dynamic nature of a child's growing skeleton means that injuries often manifest differently compared to adults, presenting diagnostic and management dilemmas that require a very specific clinical eye. What appears simple on the surface can have significant long-term implications if not managed appropriately. Our aim today is to provide you with a comprehensive understanding of the current clinical landscape for these presentations, honing in on those critical distinctions and decision points that truly matter for patient outcomes.
So let's unpack this. Before we even consider specific injuries, it's vital to truly appreciate how a child's musculoskeletal system fundamentally differs from that of an adult. It's not just a miniature version, is it? Can you elaborate on these key distinctions and, crucially, their orthopedic significance for our listeners?
That's an excellent starting point because you're right, it's far more than just a size difference. What's fascinating here is that children's bones are inherently more porous than mature adult bone. Imagine a honeycomb structure. A child's bone has larger, less dense spaces. This inherent porosity makes them susceptible to quite unique fracture patterns that we simply don't typically see in the adult population. For instance, this leads to specific injury types, such as torus or buckling fractures and green stick fractures.
Ah, the green stick fracture, the classic pediatric injury.
Exactly. A green stick fracture, for instance, is a partial break where one side of the bone fractures while the other side remains intact and actually bends. It's very much like attempting to break a young, supple tree branch. It doesn't snap cleanly through, it splinters and bends. These types of fractures most commonly affect the long bones of the forearm, specifically the radius and ulna, but they can certainly occur in any long bone throughout the body.
And clinically, what are you looking for? How does it present differently, perhaps?
Well, clinically, when a child presents with a green stick fracture, you'll typically observe localized pain, swelling, and tenderness over the affected area. There might be some notable deformity, though often it's less pronounced than with a complete fracture. The child will likely have a history of a fall or trauma and will demonstrate a reluctance to use or bear weight on the injured limb with limited range of motion.
Okay.
On physical examination, you'll find point tenderness and mild to moderate angulation, crucially, with intact soft tissues and no complete displacement of bone fragments. Unlike complete fractures, you generally won't find crepitus due to the partial nature of the break, and there's often a preservation of periosteal continuity on the side of the bone that remains intact.
Right, that intact periosteum again.
Exactly. While pain is usually less severe than with other fracture types, it can still be very distressing for a young child.
That young tree branch analogy really paints a picture. So if a green stick fracture is like a bent twig, what's the single most common misconception or diagnostic trap that clinicians, especially early in their careers, fall into when dealing with them? What's the one thing they might miss if they're not thinking specifically about that twig analogy?
That's a critical question. The biggest trap is underestimating the potential for angular deformity. Because it's a partial break and the child might still have some function, there's a temptation to think it's not that bad.
Right, dismiss it almost.
Precisely. But even subtle angulation in a green stick fracture, if not properly reduced and immobilized, can lead to persistent deformity. The classic mistake is not getting good enough AP and lateral views or not appreciating that even a seemingly small bend needs addressing. While remodeling is amazing, it has its limits, especially for rotational or significant angular deformities, and we often see these present in the distal radius.
Okay, so distal radius is a common spot.
Very common. This type of fracture, whether from a fall or even a direct blow to the forearm or shin, is easily identified on an X-ray, as it clearly shows a long bone fracture that hasn't completely severed the bone. The primary risk factor, naturally, is young age, given the softer bone composition in children who are frequently engaged in activities with a high risk of falls.
And non-accidental injury, is that a common cause?
Well, non-accidental injuries are more typically associated with spiral or twisting fractures, but it's important to remember that a direct blow could certainly result in a green stick fracture. So you always have to consider the whole clinical picture.
So it's about seeing the subtle problem before it becomes a bigger one. How then do we manage them? What's the approach?
Treatment for a green stick fracture usually begins with a reduction if the bone segments are angulated rather than already straight and aligned.
Okay, so if there's a bend, you straighten it.
Exactly. Following reduction, a well-molded cast is applied to immobilize the joints above and below the fracture site. A follow-up X-ray is typically performed about 7 to 10 days after casting to ensure that the bone alignment is maintained and healing is progressing as expected.
And is casting always necessary?
Occasionally, for significant angular deformities, more advanced techniques might be necessary to aid bone remodeling. But, it's worth noting that some experts even suggest that simple splinting might suffice in certain cases rather than a full cast,
Oh, interesting. When would that be?
particularly for minor angulations in very young children with significant growth remaining. There's some debate, but the potential for remodeling is highest then.
Okay. So porosity and green stick fractures. What else is fundamentally different?
Beyond the bone's porosity, the periosteum in children is also much thicker and significantly more resistant to tearing than in adults.
Right, you mentioned that holding the green stick together.
Precisely. This means it frequently remains intact on one side of a fracture, which can be a real advantage. This intact periosteum can actually decrease displacement and notably increase the stability of the fracture itself. It acts like a hinge, holding the broken pieces together.
Which must aid healing, too.
Absolutely. Furthermore, this thick periosteum possesses increased osteogenic capability, meaning it's highly efficient at forming new bone. This contributes directly to faster healing times in pediatric patients, making non-union, a failure of the bone to heal completely, an exceedingly rare occurrence in this population.
That's a crucial advantage for pediatric patients, that rapid healing. But does this dynamic growth, this incredible capacity for remodeling, also present unique challenges in diagnosis or management?
It absolutely does. This raises an important question. How does this dynamic growth influence injury patterns and our decision-making? The new bone growth that occurs at fracture sites in children generally lays down in the plane of motion of the joint. This remarkable capacity allows for a greater tolerance of angulation and, crucially, a significant degree of self-correction of longitudinal malalignment.
So bent bones can straighten out over time.
To a significant degree, yes. This remodeling potential is particularly robust if the child has at least 2 years of growth remaining, which gives the bone time to correct itself as it continues to lengthen and mature.
But there are limits.
Oh, definitely. The caveat here is that while longitudinal and angular deformities can often remodel, rotational deformities, a twisting of the bone, rarely, if ever, correct themselves and must be addressed accurately at the time of injury.
That's a critical distinction about remodeling. It really highlights why the orthopedic approach to children's fractures can differ so much from adults. And then, of course, there are the growth plates. These are structures unique to children, aren't they, and profoundly impact how we think about injuries.
Precisely. Growth plate, or physeal injuries, are indeed unique to the pediatric population and represent a distinct challenge. These plates are inherently weak structures, primarily composed of cartilage, which makes them considerably more vulnerable to injury than the adjacent ligaments and tendons that might otherwise be damaged in an adult.
The weak link, essentially.
Think of it like the Achilles heel of a child's long bone. It's the weakest link. Recognizing a physeal injury is absolutely paramount because if not identified and managed appropriately, it can lead to growth imbalance and potential long-term deformity.
And that's where the Salter-Harris classification comes in.
Exactly. To specifically describe and classify these critical injuries, we use the Salter-Harris classification system, which helps guide our management strategies from type I, a simple slip through the growth plate, to type V, a crushing injury to the growth plate that carries the highest risk of growth arrest.
Okay, so armed with that fundamental understanding of the pediatric skeleton and its unique strengths and vulnerabilities, let's move on to acute arm injuries. These are, of course, a common presentation in emergency departments and clinics, from minor tumbles to more serious incidents. How do we approach the clinical evaluation of a child with an acute arm injury, and what diagnostic tools are most effective to ensure we don't miss anything critical, especially given those developing bones?
If we connect this to the bigger picture, a detailed history is always the starting point. This should comprehensively cover the mechanism of injury, how it happened, the forces involved, and factor in the child's developmental level, as this can often help us predict the type of injury that might be present.
A toddler falling off a sofa versus a teenager tackling in rugby.
Exactly. Very different forces, different likely injuries. However, any history that appears vague, inconsistent, or doesn't quite fit the observed injury pattern should immediately raise concern for non-accidental injury, prompting a deeper, safeguarding-focused inquiry.
Always have that index of suspicion.
Always. Following a thorough history, the physical examination must meticulously assess the neurovascular status of the limb. This is a critical step that needs to be performed both before and immediately after any splitting or reduction procedures, as changes can indicate complications requiring urgent intervention.
So pulses, sensation, motor function, capillary refill. The basics, but absolutely crucial here.
Absolutely. We systematically palpate the injured area, as well as the joints directly above and below the injury, looking carefully for any deformity, eliciting pain, assessing for swelling, and noting any abnormal motion.
And when it comes to imaging, especially considering the developing nature of a child's bones, what's the best practice? You mentioned those ossification centers earlier. How do they play into accurate radiographic interpretation?
Right. The injured extremity should be properly splinted before radiographs are obtained to prevent further injury and reduce discomfort. And appropriate analgesia should always be administered to ensure the child is as comfortable as possible during the process.
Splint first, image second.
Yes. For X-rays, at least 2 perpendicular views, typically anteroposterior and lateral, are essential to gain a comprehensive understanding of the injury. And it's crucial that the images include the joints above and below the injury site.
Why above and below?
This broader view helps rule out associated injuries or dislocations that might otherwise be missed, particularly in conditions like a Monteggia fracture, where a forearm fracture is paired with an elbow dislocation.
Yeah,
You might miss the dislocation if you only X-ray the forearm.
got it. And the elbows specifically, you said they're tricky?
They are. For elbow injuries, which can be particularly subtle and challenging to diagnose in young children due to the cartilaginous nature of their developing joints, a thorough knowledge of normal alignment and the average ages of appearance for ossification centers is critical. These ossification centers turn to bone as a child grows, making X-rays look very different at various ages.
The cricomnemonic comes to mind.
Exactly. To give you some key milestones, remember the mnemonic CRIDO for the sequence of appearance. Capitellum, around 1 year. Radial head, 4 to 6 years. Internal, that's the medial epicondyle, 4 to 5 years. Trochlea, 8 to 10 years. Olecranon, 6 to 9 years. And external lateral epicondyle, 10-12 years. Knowing these approximate ages helps you interpret what you should be seeing.
That's a lot of crucial numbers and ages, Professor. For our listeners who are navigating a busy emergency department, are there 1 or 2 of these ossification centers that are most commonly missed, or whose presence is a definitive red flag that absolutely cannot be overlooked?
Absolutely. The medial epicondyle, the IN CRIDO, is frequently avulsed pulled off in elbow dislocations.
So it gets trapped in the joint.
It can, yes. Seeing it displaced or actually trapped within the joint space on X-ray is an immediate red flag, requiring urgent orthopedic attention for reduction, possibly surgical. Another one is the capitellum. Its early appearance means it's a good reference point, and checking its alignment is crucial for diagnosing those subtle supracondylar fractures.
And if something is missing, when it should be there.
Yes, the absence of expected ossification centers for a child's age, or significant asymmetry compared to the other elbow if you get comparison views, can also be a subtle but significant sign of underlying pathology. It might indicate a previous injury or a developmental issue, often requiring further investigation.
Okay, so CRIDO isn't just for exams, it's vital clinically. What about alignment lines?
Crucial. On a true lateral elbow X-ray, we use specific alignment criteria. The anterior humeral line, drawn along the front edge of the humerus shaft, should ideally intersect the middle third, or at least the posterior 2/3, of the capitellum. If this line passes through only the anterior third of the capitellum, or completely anterior to it.
That suggests the distal bit is pushed back.
Precisely. It can be a subtle but highly indicative sign of posterior displacement of the distal fragment, strongly suggesting an occult supracondylar fracture, even if a fracture line isn't immediately obvious. Another crucial alignment check is that the radius should always point directly to the capitellum in all views. like a line drawn through the center of the radial neck and head should pass to the capitellum.
And if it doesn't?
If it deviates from this alignment, you should immediately consider a potential elbow dislocation. A Monteggia fracture, remember that's an ulna fracture, with a radial head dislocation, a lateral condyle fracture, or a radial neck fracture. Missing these alignments can lead to devastating long-term complications like loss of motion or deformity.
So subtle lines can mean big problems. Anything else on X-ray to look for?
Yes, another subtle but incredibly important radiological sign, particularly in the elbow, is the posterior fat pad sign.
Ah, yes, the fat pad sign.
On a true lateral X-ray, its presence is seen as a radiolucency, a dark shadow posterior to the distal humerus, nestled in the oldocon fossa. Normally, you don't see it clearly. This sign, first described back in 1954, even without a clearly visible fracture line, is highly predictive of an occult fracture.
Why is that?
Because bleeding from an unseen fracture within the joint capsule expands the capsule, pushing the posterior fat pad out of the fossa and making it visible on the X-ray.
So even if you can't see the break, the fat pad tells you there's likely bleeding from one.
Exactly. When this sign is present, it warrants conservative treatment as a non-displaced fracture, usually with immobilization and follow-up. The presence of a joint effusion, which you might see as a visible anterior fat pad pushed upwards like the Sales sign, is also helpful in identifying these non-displaced fractures.
That's incredibly detailed on the diagnostic front. It highlights the importance of not just looking for a clear break, but understanding the subtle signs in a developing skeleton, which I imagine can be easily missed in a busy department. Let's move on to some of the more common acute injuries we encounter in children and their typical management pathways. For our listeners, what are the key diagnostic challenges and critical management points for a few of the most impactful acute arm injuries?
Certainly. Let's first discuss some of the most frequent and impactful acute pediatric arm injuries, focusing on key challenges. Clavicle fractures are among the most frequent fractures seen in children. Very common indeed.
The collarbone break.
That's right. They often occur in the area between the middle and lateral thirds of the bone, typically as a result of a fall directly onto the shoulder or an outstretched hand. The child will experience pain with upper arm or neck movement, along with local swelling and tenderness. Pretty obvious usually.
And treatment, usually just a sling.
Treatment typically involves immobilization with a figure-of-8 bandage or a simple sling and swab for about 3-4 weeks. Reduction is rarely needed.
Unless
the displacement is severe or there's tenting of the skin, meaning the bone fragment is pushing so sharply against the skin that it creates a raised tent-like appearance. That's a clear sign of immediate soft tissue compromise and requires urgent orthopedic assessment, possibly reduction.
Okay. What about the elbow again? Supracondylar fractures seem particularly important.
They are. Supracondylar humerus fractures are arguably the most critical elbow fracture in children, usually affecting those aged 5-7 years, and account for a significant percentage, about 60% of all pediatric elbow fractures. They typically result from a hyperextension fall into an outstretched hand, Fuchs injury.
And the Gartland classification is key here.
Absolutely crucial for guiding treatment. Type I are non-displaced. Type 2 are angulated, but with the posterior cortex still intact like a hinge. Type 3 are completely displaced with no cortical contact. And there's also a Type 4, which describes instability in both flexion and extension.
So understanding these Gartland classifications isn't just about memorization, it's about immediate, high-stakes decision-making. Can you paint a picture of a common clinical dilemma you face with a Gartland Type 2 or 3 professor?
Absolutely. A Type I fracture is generally immobilized in a long arm posterior splint with the elbow at 90 degrees flexion and close neurovascular monitoring. Simple enough. The dilemma often arises with Type 2, 3, and 4 fractures. Given their instability and significant risk of neurovascular injury, particularly the brachial artery and median nerve.
Which run right across the front there.
Exactly. These often require prompt orthopedic consultation, reduction, and frequently percutaneous pinning, usually with K-wires, to stabilize them surgically. The critical clinical scenario, the one that keeps orthopedic surgeons awake at night, is the pink but pulseless hand following reduction.
Meaning the hand looks perfused, warm, good capillary refill, but you can't feel a radial pulse.
Precisely. This is a surgical emergency. It implies the artery might be kinked, in spasm, or even trapped, despite the collateral circulation keeping the hand pink for now. It requires very careful consideration for surgical exploration of the artery to prevent the devastating long-term complication of Volkmann's contracture. That's a severe, irreversible contracture of the forearm muscles due to ischemia, leaving the hand clawed and non-functional.
A catastrophic outcome.
Truly.
Well,
Also, look out for the pucker sign, a dimple in the skin anterior to the elbow. That can indicate the sharp proximal bone fragment has penetrated the brachialis muscle, suggesting it might be buttonholed through and irreducible by closed means.
so supracondylars high risk, need careful assessment and often urgent intervention. What about nursemaid's elbow? That's much more common, isn't it?
Oh, much more common. Nursemaid's elbow or radial head subluxation. This is an extremely common injury, especially in children aged 1 to 3 years, though it can be seen up to age 5. Toddler's elbow. It's characteristically caused by longitudinal traction on an extended, often pronated, arm. The classic scenario is an adult pulling or swinging a child by the arm or lifting them suddenly by the wrists.
The annular ligament slips.
Exactly. What happens is the annular ligament, which normally holds the radial head snugly against the ulna, slips over the head of the radius and becomes trapped in the radiocapitellar joint.
That's a scenario many parents can relate to, that sudden pull. What are the key clinical signs that help us immediately identify nursemaids, especially since X-rays are often normal? And what's the typical aha moment in treatment?
Clinically, the child often presents holding the arm partially flexed and pronated close to their body and will refuse to use it. They're often quite distressed, but can be comforted. Crucially, there's typically no significant swelling or bruising, and X-rays are usually normal, but may be done to rule out fractures if the history isn't classic or if reduction fails. The diagnosis is purely clinical.
So history and presentation are key.
Absolutely. The aha moment in treatment is this spill quick reduction maneuver. We now favor hyperpronation of the forearm with gentle pressure over the radial head, which has shown higher success rates and less perceived pain than the traditional supination flexion method.
And you often feel a click.
You might feel a subtle click as the ligament pops back into place. Immediate relief is common, with the child often starting to use the arm normally again within minutes, which is incredibly satisfying to witness for both the clinician and the parents.
Always a good feeling. Does it recur?
Yes, recurrence happens in about 20% of cases, often in children with generally looser ligaments. It's an urgent issue that requires prompt medical attention. It shouldn't be left untreated, although some suggest it can self-correct. Relying on that isn't advisable.
And oddly, left arm more common, and girls slightly more than boys.
That's what the epidemiology suggests, yes. Perhaps due to right-handed parents pulling the child's left arm.
Interesting. Okay, what other common acute injuries should we be aware of? Forearm fractures.
Yes, forearm fractures involving both the radius and ulna are exceedingly common, especially at their distal ends near the wrist, which are significant growth areas. These can present as green stick fractures, as we discuss, or as plastic deformation where the bones are bowed without a clear fracture line due to compressive or bending forces.
Just so the bone bends but doesn't break.
Exactly. Or as torus or buckle fractures, which are common distal fractures, where the cortex shows buckling or angulation on one side, like a dent, but no true break through the bone. Very stable usually. Treatment varies based on fracture type and alignment. Rotational deformities, or significant angulation, say greater than 10-15 degrees depending on age and location, typically require orthopedic consultation for reduction.
And the buckle fractures.
Torus fractures, the buckle ones, are often managed quite simply with a volar splint or a removable brace, or sometimes a short cast, for 3 to 4 weeks. They heal very reliably. Also worth mentioning are radial head and neck fractures. These are more common after age 5, presenting with restricted elbow motion, particularly rotation, pronation, supination.
And they can refer pain elsewhere.
Yes, surprisingly, they can refer pain distally to the wrist. Orthopedic referral is highly recommended due to the potential for complications like permanent loss of motion and rarely a vascular necrosis of the radial head.
Right. Finally, sprains and strains, less common in the very young.
Yes, sprains, ligament injuries, and strains, muscle tendon injuries. They're generally less common in very young children, primarily because their growth plates, the physes, are often weaker and thus more prone to injury than their adjacent ligaments or tendons under the same force. The physis fails before the ligament tears.
So you suspect a physeal injury first in a younger child with joint line tenderness after trauma.
Absolutely. But in older children and adolescents, sprains and strains become more common. Initial management typically follows the RICE-E protocol: rest, ice, compression, and elevation, along with appropriate pain relief and activity restriction. While these usually heal quickly, restricting activity properly is crucial to prevent re-injury, with the highest risk being in the first 2 months post-injury.
It sounds like there's a wide spectrum of acute injuries, from those requiring immediate surgical intervention to those that can be managed at home. How do we guide parents and even junior colleagues on when to seek urgent medical attention versus when home care is appropriate for these types of arm injuries? Clear pathways must be essential here, especially for those first few hours post-injury.
This is indeed where clear clinical pathways become invaluable, ensuring appropriate and timely care. We often use a sort of traffic light system. For arm injuries, urgent help via A&E or phoning 999, the UK's emergency number, is immediately needed if you observe any of the following red flags. A significant change in the shape of the arm, like obvious deformity or angulation. Bleeding that doesn't stop when direct pressure is applied. Something embedded in the wound, like glass or a large splinter. Visible bone sticking out an open fracture. Or if the child is under 2 years old. Injuries in very young children always warrant immediate expert evaluation due to their vulnerability and difficulty in articulating symptoms.
Okay, those are clear emergencies. What about the next level down, the amber flags?
Right. Amber flags indicate a need for help via NHS 111, the non-emergency medical helpline, or a local urgent care center or minor injuries unit. These include situations where the child cannot move the arm properly due to pain after about an hour, even after painkillers like paracetamol or ibuprofen have been administered. Other indicators are swelling that isn't improving or seems excessive, any tingling or numbness in the limbs suggesting nerve involvement, pale or cold fingers suggesting vascular compromise. These are urgent signs.
Definitely need checking out quickly.
Also, if the injury is an animal or human bite due to the high risk of infection, or if the child has a wound and is not up to date with their tetanus immunization, although that's rare now with the routine UK schedule.
Okay. And then the green category, minor injuries.
Exactly. For minor injuries where the pain is mild and isn't significantly affecting normal activities, or if the cause of the injury is clear and harmless, such as a small cut or a bruise, self-care at home is often sufficient. This involves giving age-appropriate doses of acetaminophen or ibuprofen for pain relief as needed. Applying a cold pack or frozen peas wrapped in a tea towel to the injured area for 15-20 minutes, maybe 4 times on the first day, can help with pain and swelling.
Rice-E principles, basically.
Yes. Rest, ice, maybe gentle compression if appropriate, and elevation. After 48 hours, if pain persists, some gentle warmth can be applied for 10 minutes as needed to increase blood flow and perhaps ease stiffness. Resting the arm for 48 hours is also advisable.
And managing expectations for recovery.
Very important. It's good to tell parents that pain and swelling usually peak on days 2 or 3, then start to subside. Swelling typically resolves by 7 days, and pain fully resolves within 2 weeks for minor soft tissue injuries. However, if the pain becomes severe, isn't getting better after 3 days, or lasts more than 2 weeks, then seeking medical attention is important. Most simple soft tissue injuries should show clear improvement within 3 days.
That's a very clear triage pathway, which is invaluable for parents and clinicians alike. What about cast care, Professor? Once a child is casted, what are the absolute non-negotiables we need to communicate to parents?
Cast care. Yes, clear instructions are paramount to prevent complications like skin breakdown, infections, or loss of fracture reduction. It's vital to meticulously keep the cast dry. Absolutely no baths without proper waterproof covers, no swimming. Even in a shower, it must be protected, perhaps with a plastic bag securely taped. Wet plaster or padding is a disaster.
What about modifying the cast?
Parents should be advised to never cut, bend, or attempt to remove any padding from the cast themselves. And the itch. Oh, the itch. Parents should be strongly warned against poking anything down the cast. Knitting needles, pens, coat hangers, you name it, we've seen it. This can cause skin breakdown, leading to sores and infection, or even damage the underlying healing fracture.
So resist the urge to scratch.
Absolutely. Antihistamines might help sometimes, or even using a hairdryer on a cool setting blown into the cast ends. Furthermore, it's crucial to emphasize that cast material, particularly the synthetic fiberglass type, can be flammable, so it must always be kept away from any open flames or extreme heat sources.
And when should they call back? What are the warning signs with a cast?
Parents should be advised to call the orthopedic clinic or return to A&E if the cast rubs or causes a sore spot that persists, if it cracks or breaks, if it gets significantly wet inside, or if it becomes loose and sloppy as the swelling goes down.
What about the fingers or toes?
Yes, crucial checks. Look for swelling above or below the cast, excessive pain that isn't controlled by simple analgesia, any discoloration, blueness, or extreme pallor of the digits, numbness or tingling, or an inability to move the fingers or toes. These could indicate the cast is too tight, or there's a developing complication like compartment syndrome.
Right. Any other advice for recovery?
Finally, For children recovering from upper limb fractures, particularly post-cast removal, ensuring adequate vitamin D intake is important to support bone healing and overall musculoskeletal health.
Diet or supplements?
Either. This can be achieved through supplements if needed, or by incorporating foods rich in vitamin D into their diet, things like fortified breakfast cereal, oily fish like salmon or mackerel, or eggs. Good bone health matters. Post-cast removal, specific exercises are usually prescribed to regain motion and strength. It's crucial that these exercises are done with the child independently, without forceful assistance from parents.
Why independently?
Because helping or forcing the child's movement can actually cause problems, increase pain, or hinder the natural process of regaining function. Gentle, active movement is key. Simple daily activities can be very effective. Throwing a ball or playing catch, engaging in games like rock, paper, scissors, doing jazz hands, wiggling fingers, even coloring or using Play-Doh can significantly aid recovery and encourage natural movement and restoration of range of motion.
Making rehab fun.
Exactly. Aiming for maybe 10 repetitions of each prescribed movement, perhaps 3 times a day, linking it to meal times, can help breakfast, lunch, and tea time. And they can continue these for as long as needed until full function is restored.
Excellent practical advice. Now, shifting gears a bit, Prof. Imam, we're seeing an increasing prevalence of overuse injuries in children, particularly young athletes. This seems like a distinct category from the acute traumatic injuries we've just discussed, often with a more insidious onset. Could you shed some light on why this is such a growing concern in pediatric orthopedics and what's fundamentally driving this trend?
Here's where it gets really interesting and, frankly, a bit concerning from a public health perspective. The landscape of youth athletics has transformed dramatically over the last few decades. Organized youth sports have seen immense growth, an estimated 30 million children participating in the U.S. alone, and we see similar trends here in the U.K. and globally.
Huge numbers.
Huge. Unfortunately, this surge in participation, often starting at younger ages and with greater intensity, has led to a significant increase in both acute and, more notably, overuse injuries. Emergency department visits for these injuries are highest among the school-age to young adult population, indicating a substantial burden on healthcare systems. The yearly costs associated with these injuries are frankly substantial, estimated to be as high as $1.8 billion globally. It underscores the scale of the problem.
And what's driving it? Is it just more kids playing sport?
It's more complex than that. The primary reason for this marked increase appears to be the pervasive trend towards early sports specialization.
Focusing intensely on one sport from a young age.
Exactly. In previous generations, children often engaged in different sports across various seasons. Football in winter, cricket in summer, maybe athletics too. This naturally allowed for varied muscle groups to develop, and crucially, provided essential periods of rest for the body parts heavily used in one particular sport. Today, it's become common practice for a child to play one sport year-round, often on multiple teams, simultaneously school team, club team, regional squads starting at increasingly younger ages.
Driven by perceived pathways to elite sport.
Often, yes. The uncomfortable truth is that for many young athletes, perceived success or progression in one sport now often comes at the long-term cost of their developing musculoskeletal health. This continuous, relentless use of the same muscle groups and movement patterns, coupled with demanding training schedules, overtraining, and insufficient rest and recovery, creates profound muscle imbalances and puts children at a serious and escalating risk of overuse injuries. Their developing bodies simply aren't designed for that kind of repetitive load without adequate recovery.
So it's really about the relentless, repetitive stress on these developing bodies, particularly during periods of rapid growth when they're already undergoing significant physiological changes. For clinicians, parents, or coaches, what are the telltale signs or symptoms that should prompt suspicion of an overuse injury, especially given they aren't tied to a single, obvious event?
That's key, the insidious onset. Symptoms of overuse injuries generally include pain that isn't linked to a single acute traumatic event. Instead, this pain typically worsens with activity and improves with rest. That activity-related nature is a key distinguishing feature and an important diagnostic clue.
Unlike a fracture, which hurts constantly.
Generally, yes. Although chronic stress fractures can ache at rest too. You might also observe swelling around the affected area, sometimes subtle changes in the child's form or technique during their sport, perhaps a pitcher losing accuracy or velocity, a runner developing a limp, and sometimes even a noticeable decreased interest in practice or the sport itself. This can be a red flag from a behavioral perspective, indicating burnout or chronic discomfort they might not be articulating well.
And the physiology makes them more vulnerable.
Yes, it's also important to remember the physiological differences in children. Their bones often grow faster than their muscles and tendons stretch to keep up. This uneven growth can lead to increased tightness and tension in muscles and tendons, making them inherently more prone to injury during growth spurts, sometimes called a relative flexibility deficit.
So growth spurts are high-risk periods.
Definitely. Furthermore, the growth plates themselves, the physes, being weaker cartilaginous structures than the surrounding ligaments and tendons, are particularly vulnerable to repetitive tensile or compressive stress. If this repetitive stress is ignored, if the child plays through significant pain, it can disrupt normal bone growth at the physis and potentially lead to significant long-term issues, including deformities, limb length discrepancy, and premature growth arrest.
Serious consequences. So, where do we typically see these overuse injuries?
Overuse injuries can indeed affect virtually any musculoskeletal structure: muscles, ligaments, tendons, bones, stress fractures, and critically, those growth plates, apophysitis. While they can occur anywhere, the most common sites in children are predictably the lower limbs, specifically the knee and the foot-heel area. These bear the brunt of running and jumping activities, followed closely by the upper limbs, particularly the elbow and shoulder, especially in throwing athletes or swimmers or gymnasts.
Let's touch on some common examples then. Lower limb first. Heel pain seems common in active kids.
Yes, Sever's disease is one of the most common causes of heel pain in adolescents experiencing a growth spurt, typically between ages 8 and 13 for girls, 10 and 15 for boys, especially those active in sports involving lots of running and jumping. It's an inflammatory condition, an apophysitis, affecting the growth plate, apophysis, in the heel bone, the calcaneus, right where the powerful Achilles tendon attaches.
So the tendon pulls on the growth plate.
Exactly. The repetitive stress from running, jumping, and the impact as the foot strikes the ground exacerbates this inflammation at the relatively weak cartilage attachment, leading to the characteristic heel pain, often worse after activity.
And management. Rest.
Treatment primarily focuses on relative rest, modifying or temporarily stopping the aggravating sport or activity until the pain settles. It doesn't usually mean complete immobilization. Additional treatments include the use of heel pads or cushioned inserts in sports shoes to absorb impact, regular Achilles tendon and calf stretches to reduce tension on the insertion point, and potentially short courses of nonsteroidal anti-inflammatory drugs, NSAIDs, to manage pain and swelling.
Does it need casting?
Rarely. In severe cases where walking is significantly impaired, a short leg cast or walker boot might be considered for a brief period of immobilization, but usually activity modification is enough. Sever's disease typically resolves completely once the growth plate in the heel fuses or hardens into bone upon skeletal maturity, though it's not unusual for it to flare up again if a child returns to high-impact activities too quickly before it's fully settled.
Okay, so Sever's in the heel. What about the knee? Osgood-Schlatter is another classic, isn't it?
Indeed. Osgood-Schlatter disease is another very common cause of knee pain, specifically localized at the front of the knee over the tibial tubercle.
That bony lump just below the kneecap?
That's the one. It results from inflammation, again an apophysitis, of the growth plate at the upper end of the shin bone, the tibial tubercle, which is where the strong patellar tendon attaches. This condition is prevalent in active teenagers undergoing a growth spurt, typically a bit older than Sever's, maybe 10, 15 years old, particularly those involved in sports requiring frequent running, jumping, or kicking.
Same mechanism, pulling on the growth plate.
Pretty much. When a child is active, the powerful quadriceps muscles contract, pulling on the patellar tendon, which in turn pulls repetitively on the tibial tubercle's growth plate. This repetitive traction can lead to inflammation, swelling, tenderness, and sometimes the prominence of the tubercle becomes quite pronounced and bony.
And management is similar to Sever's?
Largely, yes. Management involves limiting activity to allow healing again, modifying or resting from the specific aggravating sports. Regular quadriceps and hamstring stretches are important to improve flexibility around the knee. NSIs can help with pain and inflammation.
Does this need casting?
Occasionally, for severe, persistent pain, immobilization with a knee brace or even a cast for a few weeks might be used, but generally avoided if possible. Symptoms usually disappear completely after the adolescent growth spurt finishes, typically around age 14 for girls and 16 for boys when the tubercle fuses, although the bony prominence often persists into adulthood.
Any long-term risks if they don't rest?
Crucially, yes. Continued high-impact stress on the tibial tubercle without adequate rest, playing through significant pain, can potentially lead to an avulsion fracture of the tubercle itself, where a fragment pulls off. That would then require prolonged absence from sports and potentially surgical fixation.
So listening to the pain is key. What about pain actually in the kneecap tendon?
Yes, that's often called jumper's knee, medically known as patellar tendinitis, causing pain typically at the lower pole of the patella or within the tendon itself. It's frequently observed in sports involving repetitive jumping, like basketball or volleyball, where the quadriceps muscle's repetitive forceful contractions stress the patellar tendon.
Can this affect a growth plate too?
Yes, in growing children, this repetitive stress can specifically affect the growth plate at the lower pole of the patella itself, a condition known as Sinding-Larsen-Johansson disease. It's essentially the patellar equivalent of Osgood-Schlatter, or severs. The primary treatments are similar: relative rest, applying ice to the area, NSAIDs, and physiotherapy focusing on eccentric strengthening and flexibility. Like the others, if a child continues activity without adequate rest, it can theoretically lead to a fracture of the lower pole of the patella, necessitating prolonged absence from sports.
Okay. And stress fractures. We think of them in adults, but they happen in kids too.
Absolutely. Stress fractures are tiny cracks in the bone surface, essentially fatigue failure of the bone. They are caused by rhythmic repetitive overloading, often from running or jumping, that occurs when muscles become fatigued and consequently transfer excessive stress to the bone faster than the bone can biologically remodel and repair itself in response.
The too much load too quickly without enough recovery.
Precisely. A sudden increase in activity intensity or duration, changing footwear, or inadequate recovery are common triggers. Most often, these affect the weight-bearing bones of the lower leg, tibia, fibula, and foot, metatarsals, navicular. Diagnosis can sometimes be tricky, requiring imaging like MRI or bone scan if X-rays are normal initially. Treatment typically requires a substantial period of rest from the aggravating activity, usually 6 to 8 weeks, sometimes necessitating protected weight-bearing with crutches or a cast or boot to ensure complete healing. Resuming activity too quickly risks a full fracture or chronic problems.
Right. Significant timeout usually needed.
Right.
Now let's turn our attention to upper limb overuse injuries. Throwing athletes seem particularly prone.
Yes, they are. These are particularly common in young athletes involved in throwing sports like baseball or cricket, or sports with repetitive overhead arm movements, such as swimming, tennis, or gymnastics. Throwing injuries in the elbow, for instance, are very common, especially in baseball pitchers. The repetitive, high-velocity, overhand throwing motion places significant valgus stress, a force pushing the elbow inwards on the structures of the immature elbow. This can lead to excessive inflammation of surrounding structures, such as ligaments, particularly the ulnar collateral ligament on the inside, cartilage, and critically, the growth plates.
And Little Leaguer's elbow fits in here.
Exactly. A prevalent condition here is medial apophysitis, often colloquially called Little Leaguer's elbow. This presents as pain specifically at the bony bump on the inside of the elbow, which is the medial epicondyle apophysis. It's due to repetitive traction stress and irritation of the growth plate at this site, where the powerful wrist flexor and pronator muscles attach. The repetitive forceful contractions during throwing lead to inflammation and sometimes even widening or fragmentation of the physis. Rest from throwing is paramount.
What about pain on the outside of the elbow?
Another significant source of elbow pain, particularly on the outside, the lateral side, is osteochondritis dissecans, OCD. This usually affects the capitellum. This is a more complex condition where a segment of the bone just beneath the cartilage surface loses its blood supply and could potentially die, soften, and even separate from the surrounding bone, often exacerbated by the repetitive compression forces between the radial head and the capitellum experienced during activities like throwing or gymnastics weight-bearing.
Who gets this?
Active children, usually over 10, adolescents are most commonly affected. The first symptom is typically activity-related lateral elbow pain in the dominant arm, which can progress to catching, locking, clicking, grinding sensations, and loss of full extension.
How is it diagnosed and treated?
Diagnosis often involves a physical examination looking for tenderness over the capitellum and loss of extension, and imaging, such as X-rays, which might show fragmentation or lucency, or often an MRI is needed to assess the cartilage and bone viability more clearly. Treatment usually begins with complete rest from the aggravating activity and avoiding impact or weight bearing on the arm. Sometimes bracing is used. Physical therapy plays a crucial role in rehabilitation later to restore strength and flexibility.
And surgery.
Surgery is considered if there's no improvement with prolonged conservative measures, or if a bone fragment becomes loose or unstable, potentially causing mechanical symptoms or risking further joint damage. The goal is to restore normal joint function, decrease pain, and reduce the risk of future osteoarthritis, which is a significant concern with OCD.
Okay. And growth plates elsewhere in the arm can react too.
Yes, stress reaction of growth plates, physis, can also occur in other areas, like the proximal humerus shoulder, in pitchers due to rotational forces, little league shoulder, or the distal radius wrist in gymnasts performing repetitive weight-bearing wrist activities. These are essentially overuse injuries directly affecting the physis itself. If these stress reactions are ignored and the aggravating activity continues, it can, in severe cases, lead to permanent damage and premature growth cessation physical arrest.
Leading to deformity.
Potentially, yes, causing a limb length discrepancy or angular deformity if one side of the physis closes prematurely while the rest keeps growing. Treatment absolutely necessitates stopping the aggravating activity for a considerable period, typically 2 to 3 months, to allow for healing and prevent irreversible damage.
And things like bursitis or tendinitis.
Finally, yes, bursitis, inflammation of a bursa, those fluid-filled sacs that cushion joints, and tendinitis, inflammation or micro-tearing of tendons, are also common overuse injuries associated with repetitive motions and overstretching in young athletes, just as in adults. Shoulder impingement causing bursitis or rotator cuff tendinitis is common in swimmers or throwers, for example.
So the emphasis across all these overuse injuries is clearly on early recognition, getting the diagnosis right, and then a comprehensive plan involving primarily relative rest, addressing biomechanical factors, targeted therapies like physio, and sometimes temporary immobilization. It's a proactive rather than reactive approach, it seems. What about prevention, especially for these young athletes who are so keen to participate and whose parents and coaches are often driven by competitive aspirations? What practical, evidence-based guidance can we offer to minimize the risk of these overuse injuries piling up?
Prevention is absolutely the ideal outcome, and is where we, as medical professionals, along with coaches and parents, can make the most significant impact. Many overuse injuries can be effectively prevented or minimized. The key strategies revolve around avoiding overdoing any single sport too intensely, too early, and critically ensuring adequate rest periods are built into training schedules between practices and between games or competitions. The American Academy of Orthopedic Surgeons, through campaigns like SIP Sports Injuries, advocates strongly for practical measures based on growing evidence,
Such as?
such as limiting the number of teams a child plays on in a single season. Children participating in multiple teams concurrently for the same sport are at particularly high risk of overuse. Furthermore, they strongly recommend against year-round single-sport participation for pre-adolescent and adolescent children. Specializing too early is a major risk factor.
So encouraging variety is key.
Absolutely. Encourage regular breaks from a specific sport during the year, ideally aiming for 2-3 months off per year, maybe not all at once, but broken up, and promoting participation in diverse sports throughout childhood. This is essential not only for comprehensive skill development across different muscle groups and movement patterns, but crucially for injury prevention by distributing the physical stresses more evenly across the body.
What about specific limits, like pitch counts?
Yes. For sports like baseball, adhering to strict age-appropriate pitch count limits per game and per season, as well as mandating rest days between pitching appearances, is vital. And ensuring young pitchers also take extended periods completely away from throwing during the year allows the vulnerable elbow and shoulder growth plates time to recover. Similar principles apply to training volume and intensity in other sports. It's also vital culturally to try and shift the focus in youth sports away from just intense competitive pressure and winning at all costs towards encouraging fun, fundamental skill building, safety, and good sportsmanship. This broader perspective naturally promotes healthier engagement and reduces the risks of burnout and injury.
And educating parents and coaches.
Paramount. Educating coaches, parents, and the young athletes themselves on the risks of overuse, the importance of rest, cross-training, proper technique, and recognizing early warning signs is crucial. They are often the gatekeepers of a child's sports participation levels.
Okay, prevention is definitely better than cure. Now, Prof. Imam, beyond the common acute and overuse injuries we've discussed, there are also rare but potentially devastating complications that orthopedic professionals must be acutely aware of. Early recognition can be truly limb-saving and life-altering. Could you walk us through those critical scenarios and how we approach your management, perhaps highlighting how they are often missed in the pediatric population?
This raises an important question. What are the subtle signs of a potentially limb-threatening or even life-altering condition that might not present as obviously in a child as in an adult? Two such conditions that spring to mind are compartment syndrome and complex regional pain syndrome. These are sometimes missed or diagnosed late in children, perhaps because they struggle to articulate their specific symptoms clearly, or the initial signs can be mistakenly attributed solely to the primary injury or even anxiety.
Let's start with compartment syndrome, a true surgical emergency.
Absolutely. Compartment syndrome is a critical, albeit relatively rare, complication that can occur following acute arm injuries, particularly high-energy fractures, like supracondylar fractures of the humerus or fractures of both forearm bones. It arises when increased swelling and bleeding within a closed, non-expandable fascial compartment, like those in the forearm, raises the internal pressure so high that it obstructs capillary blood flow and venous return.
Cutting off the circulation within the muscle.
Essentially, yes, it obstructs the microcirculation first. If not promptly diagnosed and treated, this leads to a dangerous reduction in oxygen supply to the nerves and muscles within that compartment. This can rapidly result in irreversible nerve damage and muscle necrosis, which in the long term can lead to permanent disability, such as the notorious Volkmann's ischemic contracture we mentioned earlier.
And the key sign, the thing not to miss.
The absolute hallmark clinical sign of compartment syndrome, the earliest and most reliable indicator, is pain disproportionate to the injury. This pain is typically described as severe, deep, constant, poorly localized, and critically, it's often markedly worsened by passive stretching of the muscles within the affected compartment. For example, gently passively extending the child's fingers will elicit excruciating pain in an anterior forearm compartment syndrome.
That passive stretch test is vital then.
It is, and the pain is often progressive and unresponsive to usual doses of analgesia, even strong opioids. The child may become increasingly agitated or withdrawn due to the severe pain.
Could you paint a picture, Professor, of a common scenario where that clinical suspicion, perhaps without all the classic signs yet, becomes the turning point?
I recall a case early in my career, a child with a seemingly straightforward displaced distal radius fracture after falling off monkey bars. They'd undergone closed reduction and casting in A&E, and initially all seemed well on the post-reduction X-ray. But overnight on the ward, the nurses reported the child was unusually irritable, inconsolable, crying constantly, and complaining bitterly of pain in the forearm that paracetamol and even oral morphine weren't touching. They were also refusing to wiggle their fingers much.
But the hand looked okay.
Exactly. When assessed, the hand distal to the cast was pink. Capillary refill was brisk, they could feel touch, pulses were palpable. But that disproportionate pain, the agitation and the pain on very gentle passive finger extension were the massive red flags.
So you didn't wait for the Ps.
We didn't wait for the classic 6PS, pain, paresthesias, pallor, paralysis, pulselessness, poikilothermia, coolness. While they're taught, the reality is that significant paresthesias, numbness, tingling, muscle weakness, paralysis, power, and pulselessness are often late findings, indicating that significant, potentially irreversible damage may have already occurred.
So the pain and the passive stretch are the early warnings.
Absolutely. If compartment syndrome is suspected based on these clinical signs, the pressure within the compartment must be measured directly, often using a specific needle manometer system like a Stryker device.
Is there a specific pressure threshold?
Yes. While clinical judgment is paramount, objective measurements help. A compartment syndrome is often diagnosed when the absolute pressure is high, for example, 30-40 mmHg, or, more reliably, when the difference between the patient's diastolic blood pressure and the measured compartment pressure, the delta pressure, is less than 30 mmHg, or even less than 20 mmHg in some literature. That indicates perfusion is severely compromised.
So if suspicion is high or pressures confirm it?
Treatment is immediate and urgent. It involves promptly splitting the cast and all underlying dressings right down to the skin along the entire length of the ling, elevating the extremity, but only to heart level, not high elevation, as that can worsen arterial inflow against pressure. And if clinical signs persist or pressures remain elevated despite these measures, the definitive treatment is an emergency surgical fasciotomy, making long incisions through the skin and fascia to open up all the affected compartments and relieve the pressure, allowing the muscles to swell outwards.
A big operation.
It is, but it's limb-saving. Early and prompt recognition, followed by definitive treatment, is absolutely key to achieving a good prognosis and preventing permanent disability. Time is muscle and time is nerve.
A crucial message. What about the other condition you mentioned, CRPS?
Yes, reflex sympathetic dystrophy, RSD, which is now more commonly termed complex regional pain syndrome, CRPS, specifically type 1 when there's no major nerve injury. This is another challenging and often misunderstood chronic pain condition that can occur in the pediatric population, sometimes after relatively minor trauma. It's characterized by severe continuous pain in an extremity, often described as burning, achy, or throbbing, that seems way out of proportion to the initial injury, if one can even be recalled. It's associated with signs of autonomic dysfunction, vasomotor instability, sweating changes, temperature asymmetry.
So again, pain disproportionate.
Yes, but a different quality of pain, often more chronic and associated with other features. The pain is typically burning, it's continuous, and it is profoundly exacerbated by movement, light touch, a phenomenon called allodynia, where a non-painful stimulus like clothing brushing the skin is perceived as intensely painful, or even emotional stress. Crucially, it often develops weeks or even months after the initial injury, which might have been quite minor, making the connection less obvious to the observer, who might unfortunately dismiss the child's persistent complaints as malingering, psychological, or attention-seeking.
What are the signs to look for?
The cardinal signs, according to diagnostic criteria like the Budapest criteria, include this persistent pain disproportionate to the inciting event, plus reported symptoms and observed signs in categories like sensory, hyperalgesia, allodynia, vasomotor, temperature asymmetry, skin color changes can be red, mottled, cyanotic, pale, pseudomotor edema, sweating changes, swelling, and mototrophic, decreased range of motion, weakness, tremor, changes in hair, nail, or skin texture. Skin can become thin, shiny.
So a whole constellation of signs.
Yes, often a combination. The child frequently guards the limb protectively, refusing to use it or bear weight on it, leading to secondary stiffness and muscle wasting. Oedema, the swelling, is often one of the first and most consistent signs. Skin discoloration can be quite striking, ranging from cyanosis to intense redness, particularly in the hand or foot.
That sounds incredibly distressing for both the child and their family, and diagnostically challenging for clinicians because the physical signs are often disproportionate to the initial injury, and there's no single definitive test. How do we approach diagnosis and management, especially given its unique presentation in children compared to adults?
The diagnosis of CRPS is primarily clinical, based on recognizing the pattern of symptoms and signs meeting established criteria, while also ruling out other potential causes to the pain and dysfunction. Imaging findings can be supportive but are not always definitive in children. X-rays might show patchy osteopenia later on. A three-phase bone scan can sometimes show increased periarticular uptake in the affected limb, particularly in the delayed phase, which can be helpful. MRI may also be useful primarily to rule out other underlying pathology.
And treatment, is it different in kids?
Treatment in children is often reported to have a better prognosis than in adults if initiated early and aggressively, but it absolutely requires a multidisciplinary team approach due to the complex interplay of physical and psychological factors. This typically involves orthopedics or rheumatology, specialist pain physicians, dedicated physiotherapists and occupational therapists, and clinical psychologists.
What does the therapy involve?
A cornerstone of treatment is intensive physical and occupational therapy focused on restoring function, desensitization techniques for the allodynia, like graded exposure to textures, improving range of motion, strength, and normal use of the limb. This often starts very gently, perhaps with mirror therapy or graded motor imagery, progressing to gentle touch, weight-bearing, and functional activities. Medications can play a role. Simple analgesics, NSAIDs, sometimes neuropathic pain agents like gabapentin or pregabalin, or low-dose antidepressants like amitriptyline have shown benefit. Oral steroids are sometimes used early on for their anti-inflammatory effects. Psychological support and coping strategies for both the child and family are vital. Transcutaneous electrical nerve stimulation, TNS, can help with pain modulation. In severe intractable cases, regional nerve blocks performed by pain specialists might be considered.
What about immobilization? Does that help?
Absolutely not. This is a crucial point. Unlike many acute orthopedic injuries, immobilization in casts or splints often significantly exacerbates CRPS symptoms and is therefore strongly contraindicated. Early mobilization, functional use, and weight-bearing, as tolerated, are paramount, even though the child might resist initially due to the pain. The goal is to break the cycle of pain, disuse, and autonomic dysfunction.
So encouraging movement is key, despite the pain.
Yes, guided by therapists. Newer treatments like gabapentin and anti-epileptic medication also used for nerve pain have shown promise by modulating central pain pathways. Again, the absolute key is early diagnosis and aggressive, multidisciplinary treatment for the best chance of favorable outcomes in this complex and distressing condition. For our listeners, if you suspect CRPS based on that pattern of disproportionate pain and autonomic signs, trust that gut feeling. Refer early to a specialist team. The patient's subjective experience of severe pain is key, even if objective signs seem initially minimal or confusing.
So we've explored the unique nuances of the pediatric musculoskeletal system, from its flexibility and remarkable remodeling potential to the critical vulnerabilities of growth plates. We've delved into common acute injuries like green stick fractures, supracondylar fractures, and nursemaid's elbow, highlighting key diagnostic pearls and management principles. We've also discussed the increasing prevalence and mechanisms of overuse injuries in young athletes, stressing the importance of prevention, and finally, the critical importance of recognizing and urgently managing those more complex, potentially devastating conditions like compartment syndrome and complex regional pain syndrome.
Indeed, what's fascinating and challenging is the sheer breadth of presentations in pediatric arm injuries and the absolute need for a nuanced, age-appropriate approach in every case. From understanding the intrinsic vulnerability of cartilage and growth plates to appreciating the subtle clinical and radiological signs that demand urgent intervention, every child's injury presents its unique considerations. The key takeaway for me, I suppose, is that a child's skeleton isn't just a small version of an adult's. It's profoundly different biologically and biomechanically. Respecting those differences, the porosity, the thick periosteum, the open physes, the remodeling capacity, is fundamental to how we diagnose accurately and manage effectively, ultimately making a lasting positive impact on their future mobility and function. Our goal in this deep dive has really been to illuminate some of these key areas, helping you refine your clinical eye and hopefully improve patient outcomes in this dynamic field.
It's been an incredibly informative deep dive. Thank you for sharing your expertise. To our listeners, we hope this discussion has equipped you with valuable insights for your practice and perhaps a deeper appreciation for the intricacies of pediatric orthopedics. If you found this discussion helpful, please do consider rating and sharing Deep Dive Ortho with your colleagues.
Thank you for joining us for this in-depth discussion. It's been a pleasure.
Join us next time on Deep Dive Ortho for another exploration into the world of orthopedic medicine.